Welcome once again into the Radiopedia Reading Room, a podcast unconcerned with books or poetry, tea leaves or palmistry. It's a radiology podcast. My name is Andrew Dixon, and joining me, he's so twisted up in knots right now, he should be careful not to strangulate himself. It's my co-host Frank Gaylor. That sounds very depressing.
You know, I am. I'm anxious and frustrated and just a grumpy mess at the moment. As you know, I've been on sabbatical for 6 months, now past tense, because now I'm back at work. And I know this will surprise you a great deal, but it just turns out that adding a full-time job, now I don't have enough time to do all the things that I got used to doing in 6 months.
You're not enjoying the work you've gone back to?
No, actually quite the opposite. And surprisingly, I've been enjoying being back much more than I thought I would. And I guess, you know, for all the criticisms of the perks of sabbatical, etc., the fact that I went away really ready to quit and hang it up and say I've had it, and now I'm back and I'm engaged and I'm enjoying teaching, and the frequency with which I find cases that I find interesting has gone up dramatically, which just goes to show that when I left, it was like, this is all boring rubbish.
Yeah.
Instead, now it's like, a fracture of, like, I collected a case of an avulsion, radial collateral ligament of the thumb avulsion fracture. It's like, that's not that common. This is excellent. So no, it was really good, but it's just too many hours of work between this and Radiopedia, and not enough days, I guess.
Something's got to give, and it's your irritability.
That's right.
So this episode, Gaylard, is a
Yes.
readful episode.
Mhm.
So yesterday I was joined by Michael Hartung, and I read him the Radiopedia article on small bowel obstruction. So that is what you and everyone else are about to listen to. And that's why I said knots and strangulation in the intro. It was related to bowels.
Mhm.
Now, I do mention it in the recording with Michael, but I should mention it up the top here as well, because pretty much today, as this podcast is released, Gaylard, we are releasing a brand new Radiopedia Abdominal CT Essentials course authored by Michael Hartung. And if you witnessed any of his teaching at our virtual conference in the past, you'll know that this course is going to be absolutely amazing. So the link will be in the description for this podcast. Get into it and enjoy it. Gaylard, anything else to say before we listen into this main segment?
Only that you mentioned that Michael was wearing some kind of cellophane or alpine jacket or something when you recorded this segment.
Yes.
And so listeners should expect it's a bit of an ASMR rustle in the background.
Yeah, I mean, anything Michael chooses to do is perfect. It's a perfect choice. But a ski jacket for a podcast recording, that's an interesting choice. He's taken the audio though. So he said, can I take the audio? I've got a friend who might try some AI thing to remove the rustles. So who knows, perhaps by the time this podcast actually goes out, they'll hear no issues at all. It'll sound perfect. It'll just be me chatting with Snoop Dogg.
Maybe the AI can bring us the ability to eat hard candy and cellophane wrappers and chew on food and then just reconstruct our voice anyway.
Yeah. Anyway, we should get into the main segment. So this is me reading the Radiopedia article on small bowel obstruction to the wonderfully rustly Michael Hartung. Let's listen in, and then Frank and I will be back for another chat in the outro. Joining me now in the reading room, all the way from Madison, Wisconsin in the United States, it's abdominal radiologist and I'm going to say master radiology educator. It's Michael Hartung. Welcome, Michael.
Oh, thank you very much, Andrew. I appreciate the kind introduction and the opportunity to visit the reading room.
It's a lovely room. I like to do kind introductions for the guests and then mean introductions each week for Gaylard. It's my style. Now, so you've been very busy, Michael, over the last month or so recording a brand new Radiopedia Abdominal CT Essentials course. It's just about to be released, probably already released if you're listening to this podcast. And so I said, how about you pick out a Radiopedia article and we'll record a readful podcast and it'll correspond to the release of the brand new course. So here we are. It was a simple plan, but of course you didn't just select an article. You selected an article and then decided to rewrite it make it even more awesome. And we roped in the help of two other Radiopedia editors, Ryan and Callum, to assist us.
Well, yeah, that's that is about right. But there was obviously excellent source material, and it was a great opportunity to get to know Ryan and Callum and do some awesome work together. So many thanks to
Yeah,
them for pulling it all together with me.
they're amazing, kind of unsung heroes in the background of the website. So thank you to Ryan and Callum. So I'm going to read the Radiopedia article on small bowel obstruction as it stands at the beginning of November 2024. And Michael, hopefully, you're going to jump in with extra pearls of wisdom and anecdotes along the way. Should we get started?
It sounds great. Let's do it.
Alrighty, here we go. I'll put my reading voice on. Small bowel obstruction, SBO, refers to mechanical blockage of the transit of intestinal contents through the small bowel. CT imaging, in particular, plays a key role in the diagnosis and can help identify the cause of obstruction and assess for potential complications. So that's the intro, and I think we'll move straight on to the next section, Michael, which is terminology. The degree of obstruction can be described as complete or incomplete, alternatively, high grade or partial, depending on whether enteric contents can pass beyond the site of obstruction. This is often inferred based on the degree of upstream small bowel dilatation. Oh, that gets us to the point of whether the term is dilation or dilatation. I said dilatation. It's probably dilation, isn't it, Michael?
Sounds sophisticated. I like it. So,
All right, small bowel dilation, the severity of narrowing at the transition point and the passage of oral contrast if it was administered. The next paragraph is closed loop small bowel obstruction occurs when the bowel is obstructed at 2 points, typically close to one another, entrapping enteric contents in a closed loop segment and leading to progressive vascular compromise with a risk of developing ischemia and infarction. The importance of this distinction is discussed in detail below, so that's what we're getting to.
yeah, that's a great start. And I think these are some of the big questions we seek to answer when making the diagnosis of small bowel obstruction on CT. The mandatory thing that we need to rule out is if there is a closed loop obstruction, as the risks for complications are so high in that setting.
Mm.
So that means taking time to carefully run the bowel, find the transition point, and account for all dilated segments. Looking at the bowel in both axial and coronal planes is essentially mandatory for confidently assessing an SBO.
Are you more of a complete slash incomplete or a high grade slash partial type of person when it comes to reporting small bowel obstruction?
Yeah, that's a great question. And I typically use the terms high grade or partial for SBO, but I don't necessarily feel like I have to assign a category every time. In many cases, I feel like it's my job to create an accurate word picture of what's going on for the surgical team so they can decide how to best manage the patient. So I'm looking for things like, obviously what is causing the obstruction and how sharp the transition point is, how dilated the upstream bowel is, and if there's any
Mm-hmm.
complications or things I'm unsure about that might prompt, for their management, more frequent serial abdominal exams or repeated short-term imaging if the patient has worsening symptoms.
Yeah, I agree. In my practice, I generally avoid using the term high grade or partial. I want to come back to the idea of building a word picture later on in the podcast when we get to the interpretation and reporting kind of section. But for now, how about we move on to the next one, which is epidemiology. So the incidence of small bowel obstruction is variable depending on the etiology of the obstruction. The most common cause of small bowel obstruction is adhesive disease, and the greatest risk factor for developing adhesions is prior surgery. We'll move on to the next section, which is diagnosis. The diagnosis is usually made through CT imaging and can be confirmed during laparotomy if surgery is required. Abdominal radiographs can serve as a first step towards diagnosing an obstruction, but do not provide information about the cause, grade, or complications of the obstruction, and thus a CT is appropriate in most cases to guide management. Michael, I know you do a lot of outreach radiology reporting in Kenya and Peru. So I guess two questions. Is it still surgical adhesions that are the most common cause for small bowel obstruction in those parts of the world, or is the pattern a little bit different? And is CT still used in the diagnosis there, or is there a lot of X ray being performed or surgery without CT?
Yeah, those are great questions. And, obviously it depends upon the specific setting, but the sites that I have experience with primarily serve larger rural populations that have limited access to medical care. So generally, if a patient's presenting with an SBO, they are less likely to have had prior surgery or even much prior medical care to predispose them for adhesions, and may even be presenting with more complications and later more advanced symptoms. So, in general, what I've observed is that there's a greater mix of causes of small bowel obstruction. So I think adhesive disease is probably still slightly in the lead, but there's other
Mhm.
causes such as malignant obstruction, either from peritoneal disease, direct invasion, or colonic or small bowel adenocarcinomas that get backed up. I've seen a variety of hernias, and then even infectious etiologies like tuberculosis resulting in peritonitis and peritoneal adhesions. Regarding the use of CT and X ray, both sites that I work with fortunately have CT scanners, but cost remains a barrier, and X rays and even ultrasounds are still used for frontline imaging for a lot of patients. Even when I was on site last year in Kenya, I recall attempting an ultrasound on a patient who had sigmoid volvulus, which I never really conceived of as an ultrasound diagnosis. And when I put the probe down, I just saw a lot of gas, and the patient was writhing in pain. And after a discussion with the surgical team, that was enough to take the patient to the OR without getting a CT where they
Yeah,
found the
yeah.
diagnosis. So
So a bit of old school surgical
yeah.
practice there. Our surgeons don't go anywhere near an abdomen unless they've got a CT to look at beforehand. We'll talk a little bit about ultrasound and X-ray for small bowel obstruction a little later. But for now, we are moving on to the next major section, which is clinical presentation. So the clinical presentation of small bowel obstruction varies according to its etiology. Gradual partial obstruction typically manifests with intermittent abdominal discomfort, decreased bowel movements, and vomiting. In contrast, closed loop obstruction presents more acutely, often with sudden onset of abdominal pain and signs of shock due to rapid vascular compromise. Vomiting may be absent in such cases, as the proximal bowel may not have had sufficient time to dilate before vascular compromise leads to symptoms of severe pain.
hmm Yeah, in terms of clinical presentation, it seems to me like more and more that a good history is hard to come by, especially when emergency department patients are often going directly to the CT scanner from triage before they're even yet
Yeah.
seen by a provider.
Go
Um,
directly to CT scanner, do not pass go, do not collect.
Indeed. Yeah. And so I personally tend to think of all acutely presenting patients in a similar category, in that they could have a variety of causes of abdominal pain or a variety of different presentations of small bowel obstruction. I do look for a few key phrases that modulate my search pattern and inform my differential diagnosis, such as history of abdominal surgery, someone reporting, similar pain compared to prior episodes of obstruction, sudden onset of severe pain, or highly alarming laboratory values such as elevated lactate or general metabolic derangements that demand an imaging explanation.
Yeah, yeah. Right. So, like nausea, vomiting, abdominal pain doesn't really help your search strategy and thought process because you're still just going to look for any acute abdominal kind of finding. But those parts of the history that feed into your pretest probability for particularly for tricky conditions is what you should be really hunting for in the history. So, AF, hypotensive, elevated lactate might lead you down a certain direction that you might not have been thinking about or looking so hard for if they weren't in the history. But generally, if it just says abdominal pain,
It
nausea,
can be
you've
anything.
got to,
Yep.
it can be anything. The next section, Michael, is pathology. And this is broken down into simple obstruction, which is non closed loop. And then we'll get to the closed loop. So for simple obstruction, a simple or non closed loop obstruction is defined by the presence of a single transition point causing obstruction. This type of obstruction can be further classified into two categories: complete or high grade, where no fluid or gas passes beyond the obstruction site, and two, incomplete or partial obstruction, where some fluid or gas can still traverse the obstructed area.
Yeah, and it's interesting that closed loop doesn't quite have an opposite term, and that we don't use open loop
Yeah.
obstruction, but simple or non-closed loop certainly gets the message across. And what we're really talking about is an obstruction with a single transition point. And we've already touched on this, but this is one of the principal tasks for when we review the CT images, is to find the transition point and follow all of the dilated bowel, not only downstream to the transition point, but back upstream to make sure that we have accounted for all abnormalities or possible surprises for the surgical team.
Yeah. And just to be clear, for those people that haven't heard the term transition point before, they almost certainly have, but It's that point where the bowel goes from being dilated to being completely collapsed, that kind of point of obstruction. That's what we're referring to when we say transition point. The article then goes on to list some causes of simple obstruction and breaks it down into two broad categories here. So there's those that are due to extrinsic compression and those where the blockage, I guess, is intrinsic to the bowel itself. So starting off with extrinsic compression, the first one is adhesions, and that's the most common. Second one is abdominopelvic hernia. And then less common causes of extrinsic compression include, and there's a list here, serosal slash peritoneal metastases. They can extrinsically compress small bowel or cause abrupt kinking by limiting its mobility, and inflammation secondary to peritoneal endometriosis, fistulas, abscesses, or aneurysms may even pull in and tether small bowel, causing kinking and obstruction by a similar mechanism to adhesive disease.
Yeah, and as a general principle, it should definitely give you pause if you find yourself suggesting or diagnosing an adhesive small bowel obstruction in someone without a surgical history. And so
Mm.
it's good to keep an open mind and consider a broad differential, particularly in those cases. So, one example fooler for adhesive small bowel obstruction that I've seen in a younger female patient is endometriosis. So that can result in serosal implants, which can cause narrowing and tethering of the small bowel, leading to obstruction and create an adhesive like pictures, but you have to kind of be considering that diagnosis as well.
So the next list is the intrinsic compression, so primary bowel pathologies, really. And this is broken down into inflammatory conditions, like Crohn's disease, tuberculosis, vasculitis, eosinophilic gastroenteritis, radiation enteritis. Then we have malignancy listed, so primary small bowel tumors like adenocarcinoma, carcinoid, GIST, lymphoma, and small bowel metastases. So they can be hematogenous metastases like melanoma, we see in Australia, and lung cancer, serosal and peritoneal metastases, so things like ovarian, colorectal cancer, peritoneal mesothelioma, pseudomyxoma, those kind of things. And then the final category we have here is the intraluminal conditions, so intersusception, gallstone ileus, a bezoar, gastric balloon migration, and ingested foreign bodies like fish bones, toothpicks. And what does it say here? Grill, brush, bristle.
Yep. Which I've seen before. Then, so if you have a metal grill brush, please
Yeah.
dispose of it. They can be quite
Yeah.
hazardous. But yeah, this is a great differential list that extends beyond just simply small bowel obstruction, but into the category of abnormal small bowel, where you see thickening of the bowel, you might see
Yeah.
ascites, you might see some areas of dilation, and you're trying to figure out what's going on. And obviously, each diagnosis tends to have unique imaging features and a clinical history that might provide additional guidance and lead you in that direction. Several of these, such as the inflammatory conditions like eosinophilic gastroenteritis or angioedema related to ACE inhibitors, would not necessarily cause an obstruction per se, but would cause bowel dilation and bowel thickening. So it's an early fork in the road when you're interpreting the scan is to consider if you're principally dealing with an obstruction with a definite transition point, or are you shifting more towards abnormally thickened, mildly dilated, and angry looking small bowel? And that would inform your
Mm.
differential accordingly. I would say the most common thing that I see early trainees get tripped up on is their first case of gastroenteritis, where you'll see small bowel thickening, maybe some mild dilation, some edema in the mesentery, and be tempted to call that a partial obstruction. And I think it's because the CT findings of enteritis are not as common as a small bowel obstruction, and it's just not yet on their radar. Another category that riffs on this concept of adhesive disease are complex small bowel obstructions related to multiple surgeries. So these are patients who may have matted down, adhered small bowel loops with multiple areas of narrowing and dilation, but may not have a clearly defined transition point. These can be really difficult to work through on imaging, obviously. And, for these patients, what I try to do is to look for significant change or complications such as abscess, leak, or ischemia. So, in other words, I'm trying to answer the question, is there anything actionable in this
Mm.
abdomen for the surgical team?
The next section, so that's the simple small bowel obstruction. We're moving on to closed loop obstruction. So, closed loop small bowel obstruction occurs when the bowel is obstructed at 2 points, typically close to one another, entrapping enteric contents in a closed loop segment and leading to progressive vascular compromise with a high risk of developing ischemia and infarction. The most common causes are adhesions, again, hernia, so internal or external hernias, and volvulus. The etiology is discussed in detail in the dedicated closed loop article on Radiopedia, so there's a link through to that.
Yeah, we could definitely do a dedicated podcast on that topic as it's so interesting and challenging. And obviously, when diagnosing a closed loop obstruction, you are identifying two transition points. What they don't tell you is that they can be very difficult to find, and that is the
Mm.
danger, especially if you feel relatively inexperienced and uncomfortable with the diagnosis. Often, the transition points are severely narrowed and right next to each other and only really well seen on one or maybe two of the imaging planes. So that's one of the main reasons I think it's mandatory to use both axial and coronal planes for small bowel obstruction review and also bringing in the sagittal when things remain unclear.
Because you've got those 2 points coming in and narrowing at the same point, you're often tempted to the proximal bit leading to the first blockage and then the dilatation after the final blockage. You kind of almost tempted to kind of track from one straight through to the next, and you kind of like miss the point that there's actually two getting obstructed at that point rather than you just thinking, oh, it goes from this one straight along to that one. So I think you can kind of get confused by the fact that there are two, makes it harder to find even one sometimes.
I agree. And I think the really difficult cases are when you have a closed loop segment and upstream dilation. And so you're,
Mm.
not only thinking, it looks like a typical small bowel obstruction, but there's actually, an isolated segment. And I think, one of the things that when you're reviewing the images that can make you think, this might be a closed loop and kind of raise your concern before even running the whole bowel are looking for things like asymmetric edema or thickening involving a segment. And I think that the asymmetric edema within the mesentery is a particularly helpful
Yeah.
clue to look for. Also, unusual configurations of the bowel loop, particularly on the coronal formats where you see clustered orientation of the bowel, kind of radial orientation of loops with the vessels converging towards the point of obstruction, or that classic C or U-shaped small bowel loops should definitely
Mm.
raise your concern that there's a point of fixation that's holding the bowel in what would be considered an unnatural position, and that's why
Yeah.
you're seeing an unusual clustering or configuration.
I've heard the term balloons on a string as well. So you've got these multiple balloons kind of
Hmm.
sitting on the string, which is kind of the mesentery holding them. I actually had a recent case on call that this reminds me of. And these kind of findings that you're describing there really triggered my spidey sense when I was looking through this case. And my suspicion of closed loop obstruction actually proved to be correct in that one. So I might come back to it later when we get to further into the podcast because we've kind of jumped ahead a little bit into radiographic features, which is the next major section. So let's crack into that. So radiographic features, and the first one is plain radiograph. So abdominal radiographs have a sensitivity of 55%, range 50 to 60% for small bowel obstruction. In most cases, the abdominal radiograph will have the following features. Dilated loops of small bowel proximal to the obstruction, and we have a link through to the 369 rule, which is talking about the degree of dilatation for small bowel is 3 centimeters on an abdominal x-ray. The 6, I think, refers to the large bowel, and 9 refers to the cecum in the 369 rule. Just a little side comment. We'll move on.
Nice.
The next point is predominantly centrally dilated loops, multiple dilated loops of bowel, the valvulae, I can never say this properly, the valvulae convergentes
Nice.
are
Well
visible,
said.
and then gas fluid levels if the radiograph is erect, especially suspicious if greater than 2.5 centimeters in width and in the same loop of bowel but at different heights. So if you've got different height fluid levels in the same bit of bowel, then that looks suspicious, suggests that the bowel's not moving. That's basically what this all means. There's not any peristalsis going on. The next point I think is important. However, obstruction, which may be high grade mechanical obstruction, may also present with the following features: the gasless abdomen. So you can have no gas in the small bowel. This can be due to vomiting, nasogastric tube placement, and the level of obstruction causing there to be no gas in there. And then the next point is string of beads sign. So very, very small pockets of gas within fluid filled small bowel. I remember my radiologist who taught me a long time ago now, she used to say, "Beware the gasless abdomen," as she showed us a case of just this abdominal X-ray that looked relatively normal on first glance, but then you
Hmm.
look at the CT and it's just completely obstructed.
Yeah, it can be quite alarming to see what you can overlook on an X-ray. And I think it's a great list with lots of wisdom in terms of plain radiograph. With respect to the first comment about the sensitivity, I think that there are some papers that report a much higher sensitivity, closer to 80 or 90% with a diagnosis of small bowel obstruction when you tightened the sample size to the proper patient populations, and
Mm,
importantly, not allow the radiologist to use the term non-specific bowel gas pattern, which I admit does not seem like a very nice thing to say in a report without following that with specific advice about what to do next, which would almost certainly be to get a CT, especially if you are
yeah.
concerned about anything. So it is a funny thing that whenever I find myself going into the non-specific territory, it's almost like a forcing function. I have to give advice
Yes.
and raise what am I specifically concerned about and what should they do next to resolve that. So, either way, while X-rays play an important role in post-operative imaging, I think it's fair to say that for the initial evaluation with a patient with abdominal pain, unless you're in a resource-constrained environment, CT is definitely most appropriate.
Absolutely. The reasoning I like to teach for not doing abdominal X-rays for suspected obstruction is that if you do abdominal X-rays and they're abnormal, then you're still going to go on and do a CT to assess for the actual cause of the obstruction, and to decide whether it's possible to manage conservatively or not. And then if the X-rays are normal or non-specific, as you just said, then you're still going to get a CT as you've got this patient with unexplained abdominal pain. So, if both roads lead to getting a CT, why not just go straight to the CT in the first place?
Yeah, no, I definitely agree. When there is a concern of serious pathology, all roads lead to the CT scanner.
But that doesn't apply for everything. So if there's any emergency physicians listening,
Yeah.
not all roads lead to the CT, just in this specific case. Okay. Now, speaking of CT, we're now up to the section on CT appearance. So, CT is more sensitive than radiographs and will demonstrate the cause in most cases. Features on CT may include dilated small bowel loops greater than 2.5 centimeters up from the outer wall to outer wall. I must admit, I never really measure it. I just kind of look and go, they look too distended. The next dot point is normal caliber or collapsed loops distally. I find this very useful, collapsed loops distally. If I see prominent small bowel loops on the CT, I then look down and try and find the terminal ileum. And if that is completely collapsed, then I know I'm likely to be dealing with something that's
Hmm.
obstructed and there's going to be a transition point for me to find, which then leads to the next dot point here, which is the small bowel feces sign.
Yeah, and I think that the small bowel feces sign is an exciting thing to learn about. Has And I have to admit it's one of my favorites. So it's almost like a cheat code in some ways that allows you to skip ahead to the transition point.
Mm,
And so the idea with the small bowel feces sign is that the enteric contents right before the transition point have been sitting there the longest and have the greatest amount of water resorption and start to get little dots of air inside that basically resembles stool. And so hence the term small bowel feces sign.
yeah, it's a fantastic sign because you don't usually get those kind of little dots in the small bowel feces. Is usually just a large bowel kind of thing, and it's one of those things where you go, all right, dilated loops, collapsed distal loops. All right, my next thing is finding the transition point. Let me just see if anything catches my eye that looks like feces in the small
Mhm.
bowel, and you'll be surprised how often you find that transition point far, far quicker than you would have by finding the small bowel feces sign first. What proportion of cases do you reckon have a small bowel feces sign, Michael? A third, a half, that kind of thing?
Yeah, I think for adhesive small bowel obstruction, probably something like 25 to 50%. And
Mm,
it is obviously like a helpful, like I mentioned, like almost like a cheat code where you can jump ahead and find the transition point, but there's still those elements of due diligence and running the dilated bowel back upstream to see where, the dilation starts, just to make sure there's no other surprises and things like that. So I think it helps you to kind of put together a quick assessment, but there's still the steps of ticking through the entire search pattern.
Back when I was training, Michael, they used to say that the small bowel feces sign, they used that as a way of implying that the obstruction was slow, like it'd been there for a while, rather than a very hyperacute kind of obstruction. But I think that's kind of gone out the window a little bit. Do you know anything about that?
Yeah, I would agree that was a teaching that I received earlier on in training, and then I think has since not really borne out to be accurate. So I think
Yeah.
You could see it in high grade obstructions. You can see it in lower grade obstructions. You could see it sometimes in patients who just have slow transit too.
Hmm.
So I think there's a variety of settings. I don't think there's any inference in terms of the grade of obstruction that would be
Yeah.
appropriate or reliable to make for that.
It's good for helping you to find a level where the obstruction is, but not for that other aspect of the assessment.
Agreed.
I should probably, given we're talking about tracking small bowel, I should give a quick plug for my free small bowel Pac-Man course on Radiopedia, which actually teaches you how to track small bowel on CT using a bit of gamification with Pac-Man steering you around. So if any listeners are wanting to practice the skill of tracking small bowel, then check that out. Or better still, grab yourself access to Michael's new abdominal CT essentials course, where you can do a bit of that as well. How do you like that, Michael? Pretty smooth bit of cross
Yeah,
promotion
this is
there.
very, very smooth. I love it. Thank you for that.
True professional. All right, so we're still in the CT section of the radiographic features, and it continues with we're back to closed loop obstructions now. So it says closed loop obstructions are diagnosed when a bowel loop of variable length is occluded at two adjacent points along its course. We've heard this a few times, but it's good just to reinforce it. It may be partial or complete with characteristic features, and these are some of the features you were talking about earlier, Michael.
Mhm.
So asymmetric mesenteric edema involving the closed loop segment. When we say mesenteric edema, we mean actual fluid in the mesentery itself, right, Michael?
Yeah, either fluid or stranding or just kind of, yeah, but
Mm.
essentially it looks like fluid density.
As opposed to just fluid in the peritoneal compartment like ascites. It's got a more specific kind of
Mhm.
association with the mesentery itself. The next point is stretching or sharp angulation slash narrowing of the mesenteric vessels as they are distorted by the entrance and exit of the closed loop. Radial distribution of several dilated fluid-filled small bowel loops. This is, kind of like that balloons on a string that I was talking about earlier. The U-shaped or C-shaped configuration of the closed loop, which often is best seen on the coronal reformats. And then the next one is the beak sign at the site of fusiform tapering, involving both ends of the closed loop. Next one is the whirl sign, reflecting rotation of bowel loops around a fixed point. And finally, we have intramural hemorrhage, which is high density fluid within the wall of the affected small bowel, and it is most prominent on non contrast imaging.
Yeah, this is a great list and it covers, pretty much all of the major findings to look for. And I think it's, worth mentioning here that even though closed loop small bowel obstructions are scary clinically and at first can be scary to the radiologist or beginning learner, that with experience and exposure to these cases, they don't have to be so intimidating. And I think the big thing would be, to make sure that you see and interact with examples of all of these findings so that you can get accustomed to identifying them and putting some of these habits into practice for the first time
Mm,
before you're in a stressful, high stakes clinical environment, such as being on call where you're facing a tough case and unsure is it a closed loop or not, and surgery standing behind you, asking you what you think. This is probably a good time to also add that if you're ever diagnosing a small bowel obstruction and you think there's some unusual features or you think that this patient may end up going to the operating room, make sure that you have a system for following up that patient and reading about how the surgical team manages the patient. And, that sort of feedback is really the best way to improve your accuracy for reading these sorts of cases.
mm. This brings me back to my recent case, actually, because the surgical feedback was quite useful in this case. So I was on call in the evening. There's a 70-year-old lady with abdominal pain and vomiting. And the radiology registrar, who had since gone home, had already put out a preliminary report for her CT saying there's dilated loops of jejunum without a transition point with associated ascites, and he favoured enteritis as the cause. And as I said, my spidey sense was aroused because there was this cluster of loops that were very distended, bit thick walled, associated with lots of mesenteric congestion and edema. And then when I looked hard, I eventually could convince myself that there were actually 2 points of adjacent transition, 2 points of kinking. And I also noticed that the sigmoid column was kind of coming across right next to this spot where these two obstructions were. But I didn't make much of that. I didn't really understand what that sigmoid colon meant. Anyway, so I went on to report it. Actually, I think I've got the wording here that I can say. This is what I added to the bottom of the original report. So I said, I think there is an abrupt transition point in the mid abdomen, and then I gave the slice. And there is a second portion of small bowel also impinged directly adjacent to this site, creating a closed loop obstruction. There is mesenteric edema and free fluid associated with the closed loop portion. Mucosal enhancement is preserved. And then I said, as a comment, closed loop small bowel obstruction with transition points in the central mid abdomen. Urgent surgical review is recommended. And then treating emergency physician notified. And I gave the time. So that's what I did. I go home, go to bed, forget about it, essentially. And then the next day, my trainee comes up to me in the corridor and he was like, "Oh my God, thanks for putting that amendment on my report. You were correct. It was a closed loop." And he looked at the surgical operative report. And when I looked up the operative note, I was greeted with this lovely description. Michael, you'll love this one, I reckon.
Hmm.
So it explained why the sigmoid colon looked a bit weird as well. So it said, single band adhesion from appendage epiploicae of the sigmoid colon to the small bowel mesentery, causing a closed loop small bowel obstruction, free fluid plus plus serous, threatened bowel loop mid small bowel. And then it went on to say adhesion was released with sharp dissection. This is the bit I like. The bowel sprang free and immediately improved in color, observed for 10 minutes, ongoing improvement, although still bruised, was seen to be peristalsing, so did not proceed to resection. Anyway, the patient did very well. A little bit self-indulgent, sorry, sharing that story on the podcast. But I think this is the kind of difference that we as radiologists can make in these settings if we put together those findings. And as I said, spidey sense, not really a radiology term, but that kind of getting that sense that this is not your typical
Hmm.
small bowel obstruction, or this is, doesn't really strike me as being enteritis. There's something going on here.
Yeah, that's a wonderful clinical story and a great outcome, obviously. So nice work catching that. And I think, reading that operative report really brings the black and white radiology images to
Hmm.
life. We start to kind of understand the patient behind the images, the surgical team who's managing the patient, and feel a sense of connectedness and just kind of almost like a three dimensionality to what we're doing.
Yeah. There are a lot of areas in radiology where we don't get that kind of feedback, right?
Hmm.
No one ever goes and checks, was there a grade 2 partial tear of the medial collateral ligament? So you never kind of get that direct feedback. But in these settings where they do go on and perform abdominal surgery, you're crazy if you don't look up the surgical notes afterwards and see what it actually turned out to be, because it's the perfect opportunity for learning and something you don't get in a lot of other areas of radiology.
Yeah, I agree. It is the best kind of learning. And, one other key element to your clinical story that I think really provided important guidance and clarity for the surgical team was how clearly you stated the diagnosis in your comment as a closed loop small bowel obstruction rather than providing a lengthy explanation of the imaging findings and the possibilities leading with that diagnosis, especially in the after hours or on call setting. Urgent presentation really can provide the clarity that's needed for the surgical team to take the patient quickly and provide treatment. So, well done in stating the diagnosis without obfuscating the diagnosis.
We haven't quite finished the CT section here, Michael. One last little bit. Strangulation refers to impaired blood flow, decreased perfusion to the small bowel caused by obstruction, which can lead to bowel ischemia. Closed loop obstructions are at particular risk for ischemia and infarction. This is mainly seen when the diagnosis is delayed, up to 10% of small bowel obstructions, and associated with high mortality. Features are non-specific and include, and a list of 6 or so things here: thickened and increased attenuation of the bowel wall, increased attenuation of bowel contents due to hemorrhage, halo or target sign, pneumatosis intestinalis, portal venous gas, and localized fluid or hemorrhage in the mesentery.
Yeah, I personally don't like using the word strangulation as synonymous with ischemia, as the cause of ischemia is not, always related to direct compression of the lumen,
Hmm.
but can be caused by, things like progressively increasing interluminal pressure, compression of the vasculature, or vascular occlusion. Probably the trickiest one on the list is thickening of the wall with increased attenuation, as that can look like increased enhancement at first glance. But in fact, if you had a non contrast CT, it would also be thickened and bright looking with increased attenuation because it's due to blood products within the wall related to hemorrhagic ischemia.
Yeah, I must say, I never use the term strangulation in my description either. I tend to just say whether I think it's ischemic, use that broad term.
Mhm.
I know some people have suggested there's a role maybe for dual energy CT, virtual non contrast, to look for that, intramural hemorrhage or hemorrhage within the bowel. I must admit that despite our scanners in the emergency department all having dual energy functionality, we don't currently use it for this purpose.
Yeah, there are certainly uses for dual energy that can be considered for acute pathology of the bowel, but it can be tricky to navigate the balance between additional information and then the number of series and number of images.
Mm,
So if you're doing a mesenteric ischemia protocol with late arterial and portal venous phases, and you add a virtual non-contrast, and then the iodine images, it ends up being a ton of images to review, even more, than an abdominal MRI, for example. Additionally, for all comers with abdominal pain, it's not exactly common to encounter a closed loop obstruction with intramural hematoma that you otherwise wouldn't be sure about.
mm.
And of course, many of these cases end up going straight to the OR anyways.
We'll move on to the next little section here, which is positive oral contrast is not usually necessary for the diagnosis of small bowel obstructions, as it tends to dilute in the setting of small bowel obstruction, does not reach the transition point, and may obscure the evaluation of the bowel wall, thereby limiting the evaluation of bowel ischemia.
Yeah, our practice tends to use oral contrast more than most, so I'm fairly sympathetic to its uses. And in general, I appreciate the additional clinical information and diagnostic confidence that it can provide. Small bowel obstruction isn't actually an absolute contraindication to receiving oral contrast, and giving it can provide some functional information in terms of high grade obstruction or partial obstruction. It's a sort of contrast challenge that can help with triage. Many patients with suspected small bowel obstruction also have another diagnosis, and there is a reported therapeutic effect for patients who are presenting with abdominal pain due to constipation as well.
Mhm.
But I acknowledge that in many cases, patients with small bowel obstruction are unable to tolerate oral contrast. I will say it should still be strongly considered in other cases, such as postoperative cases, because it can help to look for other pathologies such as bowel leak or complications related to surgery.
Yeah, we haven't used positive oral contrast for, emergency abdominal CT scans at our hospital for probably 10 years or more now. I don't think any of us particularly miss it. Does it delay the scan much for you? Like, how long do you wait until the oral contrast has been administered before you go and do the scan? Because jokingly, that is the only reason that I miss the days of oral contrast, because there was the chance that the scan that I've just protocoled will be delayed for a few hours and some other sucker rather than me is going to have to report it.
Yeah, we don't routinely give oral contrast for all patients in the emergency department, but we do in certain scenarios. So if a patient is recently postoperative, a cancer patient, I think a particularly high yield patient is a thin patient where we
Mm,
think it will help to evaluate the bowel and everything is kind of packed in, or patients who cannot get intravenous contrast. In the emergency department setting, we mix the oral contrast with some polyethylene glycol to help move things along. And so it adds about 1 hour of scan delay.
mhm. We'll move on to in uncomplicated cases of adhesional small bowel obstruction, where complications such as ischemia or perforation are absent, a water soluble contrast challenge may be employed. This approach serves both diagnostic and therapeutic purposes.
This is a common and useful technique for surgical triage. And basically, you give oral contrast and do serial x rays to see if it reaches the colon within 24 hours, which indicates a high chance of successful management non operatively. And we do this at my institution, and I imagine most institutions are doing something like this.
Yeah, absolutely. We do this in, in those cases where the surgeons are wanting to take a conservative approach. They're pretty much the only abdominal X-rays that I see these days, to be honest. Other than pre-MRI screening, looking for foreign bodies in unconscious patients. So, how long after the oral contrast in this setting do you take your first X-ray?
Yeah, the first x ray is at 8 hours, and then the second would be at 24 hours if it had not yet reached the colon
Yeah.
after that first x ray.
And I'm always surprised, even though they've had a CT that looks like a fairly high grade obstruction, I'm always surprised how often these people who have these challenges, you do the 8 hour x ray. I think sometimes we do them even earlier than that, like 4 hours, and contrast has already made it all the way to the large bowel. And then there's obviously the other cases where you look at it after 8 hours and the proximal small bowel loops are massive and there's just this dilute contrast in there. And essentially at that point, you don't even need to wait 24 hours. this is not really going anywhere.
Mhm.
But it's very, very useful test.
Yeah, I agree, and certainly for the first patient population, it's astonishing to see how many people make it to the colon. It's very exciting, but
Mm,
then the others where
mm.
it's really dilute and not going anywhere. Sometimes I'll even recommend redosing those patients because I feel like as it continues to dilute through the remainder of the dilated bowel, there's no
Yeah,
way
yeah,
I'm going to
yeah.
see it reach the colon. So
Exactly. It's almost it becomes a homeopathic dose
yeah.
of contrast after a while. All right, the next section is imaging modalities that aren't as important as CT. So we've got MRI, ultrasound to finish things off here. So MRI is not commonly used in the diagnosis of small bowel obstruction, but has a role for the evaluation of pregnant patients for whom ionizing radiation is contraindicated. That's all we say.
Yeah, this is quite rare, but it's helpful to be comfortable reviewing these kind of images. The more common scenario that I've seen in the setting of pregnancy is MRI for appendicitis after ultrasound fails to find the appendix or to look for renal stones.
Hmm.
And usually the coronal SSFSE, which is basically like a T2 weighted sequence, or the T2 fat suppressed images can help to provide the answer.
Approach them like you're kind of looking at a CT scan, pretend it's not an MRI, and that gets you by most of the time or not?
In general, yes, except sometimes with MRI you find that you're just picking the one sequence that doesn't have motion degradation. That makes
Yeah,
it,
yeah, 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 yeah.
basically non-diagnostic. So that's the one thing with MRI is that, in theory it can be quite good, but in practice when a patient's moving around, it can, you may only have that's why I mentioned the coronal SSFSE because it's
Mm.
often not infrequently the one good series that you can work
Yeah,
through to figure out what's
quickly
going on.
acquired as well. Yeah. And finally, the ultrasound section, I'm going to just skim read this one because it's mainly an indirect way of assessing for obstruction. So, ultrasound findings suggestive of small bowel obstruction include, and we have a list, dilated loops greater than 3 centimeter diameter, ineffective peristalsis, and that results in the to and fro or whirling appearance of the intraluminal contents. There's a nice case on Radiopedia showing that to and fro sign. So, basically, you can see the contents in the distended small bowel just going back and forward, not moving along properly in those cases. That's quite cool. Findings suggestive of bowel ischemia or infarction on ultrasound. So, extraluminal free fluid. The pointy triangular appearance of interloop free fluid is sometimes referred to as the Tanga sign. Loss of peristalsis, bowel wall thickening greater than 3 millimeters, and mural gas. So I consider it a little bit like an abdominal X-ray, the ultrasound, in terms of what it can kind of tell you, maybe with the benefit of being able to show loss of peristalsis in
Mhm.
addition. But I guess that's implied on your X-ray by the fluid levels.
Sure, it's certainly not commonplace, but it's interesting to consider the applications for point of care ultrasound and also for resource limited areas.
Well, let's move on to something that's definitely important, and that's the next section, which is radiology reporting. And I guess this is where I want to come back to the idea of building a word picture in your report for the surgical team to read. So, key features to include in the radiology report, and we have 5 dot points listed here. The first one is whether the obstruction is simple, single point obstruction, or closed loop. I think that's been a major focus of this podcast today. The second one, location of obstruction and the appearance of the transition point. The third one, number of points of obstruction, especially in obstruction secondary to serosal disease or small bowel tethering by infective or malignant disease. And then the fourth one is your favored etiology. And then the fifth one is presence of complications such as perforation or ischemia.
That's a great checklist. And in general, I would err on the side of being descriptive and understand that, especially in less straightforward cases, that the surgical team doesn't necessarily need you to be 100% definitive in all cases, especially when it's not feasible due to a complex appearance or multiple variables, but rather help them to understand the imaging findings with an accurate, detailed word picture so they can combine our description with their clinical assessment and decide on the patient management appropriately. The question that I keep asking myself is there anything actionable in this study? Particularly, would there be anything that would change management or push from conservative, non operative management to operative management? This is particularly relevant for complex postoperative patients, like we talked about, who get serial CTs during their long inpatient stays. And in general, keeping things as focused and action oriented as possible also decreases our stress when reading
Mhm.
the studies, and it makes them more readable so your colleagues know what to look out for and what to follow up in future studies.
To that end, what would be a nice, like an example of a fairly typical conclusion or impression that you might write for a CT report for small bowel obstruction?
I do try to make it a point that the impression or the conclusion is thorough enough and has enough information that I'm not forcing the reader to go back and read the findings section. That can be considered supplemental information, but not necessarily mandatory to get a sense of a reasonably complete picture.
Mhm.
So that does mean for me leading, like you did in your example, leading with the actual category of disease or favorite diagnosis, and then providing details to follow. So, for example, if there's a straightforward case of recurrent obstruction that happened in the same place as 3 months ago, and they were treated with adhesive disease, I might simply state something like small bowel obstruction with abrupt transition point in the distal ileum, likely related to adhesive disease in the same location as 3 months ago.
Mhm.
Or let's imagine a closed loop obstruction. And for those cases, making the diagnosis crystal clear is really paramount so that the surgical team can appropriately manage the patient. So I might say something like closed loop small bowel obstruction involving a cluster of distal ileum in the right lower quadrant. There's high suspicion of hemorrhagic ischemia of this segment based on high density wall thickening. Of course, there are more complex cases where the bowel is dilated, but you can't quite find the transition point. So you might, in those settings, be painting more of a word picture.
A bit more nuance in those cases. Yeah, that's all very similar to my approach. And yeah, as we said kind of earlier, the high grade versus partial is not really something that I tend to throw into the conclusion of the reports. And it's really those other descriptors that I focus on, particularly
Hmm.
those complications, but also the location. I feel like sometimes I see trainees' reports where they've reported it, but they haven't actually specified where it's going on. And I would imagine that would be useful for the surgeons to know potentially where they're going to have to look when they go in if they are going in. So where it is, what's happening at that transition point, and any kind of complications that you suspect, and obviously make a lot of the possibility of closed loop.
Hmm.
The final little section here, or final two sections, treatment and prognosis, and then we have a little section on differential diagnosis to finish this podcast off, Michael. So, treatment and prognosis. So, non operative treatment of small bowel obstruction usually consists of gut rest and a decompression via a nasogastric tube. Parenteral fluids or nutrition are typically given in conjunction with this. Water soluble contrast challenges are used for diagnostic and therapeutic tool. We discussed that earlier, so I'll skip over that. And then obviously, there are cases that go to surgery. The final section is differential diagnosis. So, main one here, I guess, or main couple here would be ileus. Clinically, it may present similarly with nausea, vomiting, and abdominal pain. You're more likely to have air in the sigmoid colon and rectum in the case of ileus, as opposed to obstruction. Diffusely dilated loops of small bowel without a transition point, including colon, are more likely to represent ileus. And recent or concurrent trauma, surgery, or infectious inflammatory process is more likely to represent ileus. And the final one here is that the feces, small bowel feces sign, is more likely to represent small bowel obstruction. Okay, so if you see that, obstruction, but I guess transition point is the key really to differentiating between these. And also ileus is, it's very much a clinical setting, as we've said. The next one here is causes of small bowel dilatation, not necessarily obstruction. So endometriosis, ischemia, enteritis, as you mentioned earlier, Michael, and also that medication-related angioedema from ACE that you spoke about earlier, as well as chemotherapy.
I think that's a great list for the differential diagnosis, and combined with our earlier discussion of different diagnoses to consider, it's really helpful to have an expanded differential, particularly for those difficult cases where the clinical presentation is atypical or you're just seeing dilated, thickened bowel, but without necessarily a discrete
Mm.
transition point.
Guess what, Michael? We have made it to the end of the article. Any final thoughts that you want to share, or should we just wrap this baby up?
As much as I'd love to wrap it up, I do want to add one last comment. And we did have a nice discussion about this, but again, let's just end on this because it's so positive, and that is follow up for these cases. We have so much
Mm,
to learn from our surgical colleagues in terms of their operative and non-operative management. It helps us to see how they interact with our reports, what they care about, what they don't care about, language that we might use that we think is straightforward that potentially confuses them. So these are all things that bring your reporting and your interpretation to the next level. And it's the best educational opportunity that we have in practice.
Perfect. Perfect way to finish the podcast, Michael. And let me thank you for joining me, not only to read this article today, but for organizing a major update to its content, and also for all of the amazing educational contributions you've made and continue to make to Radiopedia. And everyone should definitely check out Michael's brand new Abdominal CT Essentials Radiopedia course. There's something in it for everyone, isn't there? So whether you're just starting out interpreting CT, or if you've been doing it for a while and you're just looking for some of those cherries to put on top of your reporting technique, this course is really, really for you. Michael, it's been a pleasure, and I'll see you again sometime soon.
Thank you for that, Andrew. And it has been a pleasure. And it's been great to discuss this important topic with you.
Excellent. And now it's over to Frank for the outro. What's he going to say? Bowel. He hates bowel, no doubt. All right. See you later.
See ya.
Thank you to Michael for joining me yesterday for that chat there. Gaylard, what's your relationship with bowel and abdominal CT like these days?
Distrust. I think it's pretty much mutual. I don't report very much, as you can imagine, but like you, we occasionally get rostered down to emergency or do the occasional weekend shift. So, I do read the occasional acute abdomen. And the older I get, like you said, you rely on your spidey sense a bit more to just, does this fit together? And I think as long as a registrar or a trainee, a resident, has read the study first, I think the combination of them first, followed by me, is pretty safe. When I'm reading things on my own, I think it's probably a little bit more concerning. In fact, not just for abdo, just recently, like this week, I was rostered in CT, and as usual, I just pick up the brains and C spines first and just knock them over. And I did a dozen neurosurgery outpatient pre-clinic non-contrast CT brains for patients that had a small subdural or something, and they were just being followed up to make sure that everything was fine.
Mm-hmm.
And I got to one, and their subdural had not gone away. In fact, it was now 1.5 centimeters in size, bilateral, acute on chronic, mass effect, etc. Reported it, called the neurosurgeons, and they said, yep, no, they're actually on the table now. We saw that, and we're operating. And there seems to be a skull fracture. And I went back to the study, and there was this 1.5 centimeter depressed skull fracture. And what hadn't been written on the notes was that between his outpatient clinic and the scan, he'd been hit on the head with a hammer. And so he had a proper hammer blow fracture, which was the most obvious fracture you could imagine.
Yeah.
And I'd completely not noticed it.
You were just in follow-up collection mode.
Yeah. And I'm sure that if a registrar, the first year trainees would pick that up. But me, I'm just like, oh yeah, no, I've seen 1,000 of these. And either the subdural goes away or the subdural gets bigger. I've never had someone between the time that someone wrote the request and they get scanned, that they get assaulted with a blunt weapon. But just how obvious the abnormality is and how much I missed it is a bit of a wake-up call, to be honest.
Yeah, spidey sense does not cure inattentional blindness, does
No.
it? Now, getting back to the topic of bowel, anything else you wanted to bring up?
Well, not much of it is bowel related, but a fair bit, because it was a really good talk. I always like listening to Michael. The first thing I just want to clarify, dilatation versus dilation.
Oh, yeah. As I said it, I was like, there's something here. I can't remember what the rule is, but there's some difference between the two.
Yeah, I couldn't remember either. So while I was listening, I looked it up. So I'll just read you, because it's a readful. I might as well read you the Radiopedia entry on dilatation versus dilation. Although many clinicians use the words interchangeably, some contend that the two words are distinct and should be used in different contexts. Dilation should be used for situation in which there has been an active process by which a structure is enlarged, for example, dilation of the pupils by an ophthalmologist. Dilatation, when the stretching has occurred pathologically, for example, dilatation of bowel proximal to an obstruction. This is, however, inconsistent, and the reality is that the standard medical dictionaries explicitly state that the two terms are synonymous with no distinction in their meaning. Moreover, there is only one verb, to dilate. There is no such word as to dilatate. That
Hmm.
is our entry.
So you're saying our article specifically mentions dilatation of bowel proximal to the obstruction,
Yeah.
and yet the small bowel obstruction article that I was reading said dilation,
Yes.
but my spidey sense automatically read it as dilatation, which is correct. So I did the correct
Yep.
thing.
I think that's right. If you're not enlarging something, then it should be
Hmm.
dilatation. That sounds like the pedantry that I live for these days.
That article sounds like it was written by you as well. Did you write it, you reckon?
No, this is, I think,
Can't remember.
Daniel Bell.
Well done, Daniel.
Daniel exceeds me in his ability to get to the
Pedantry.
minutiae of these things. I highly approve.
Anything else to chat about, Gaylard?
Well, we've spoken about this before, I think, but whenever Michael speaks, regardless of the topic, I think the fact that he's so
That he's
careful,
wearing a ski jacket is annoying.
the fact that he's so careful and thoughtful about how he reports really comes through. And this idea has been going around in my head a little bit lately because of all these products that are AI driven that purport to create conclusions for you. And I saw another one where ChatGPT can be used to summarize radiology reports. And so you
Hmm.
have this ridiculous situation where we just randomly describe some things that we see. AI formats it into a report and creates a conclusion. We then send this very long, overly long report to clinicians who use AI to summarize it back down to just the pertinent findings. And
Yeah.
maybe we could just focus on having short, pertinent reports with no AI
Yeah.
involvement. But Michael and I co-authored a paper years ago, along with Ian Bickle and Jeffrey Kane, that got published in Radiographics, how to create a great radiology report. And I think these days it's more relevant than ever because the pressures for radiologists to just become data entry clerks rather than put a
Hmm.
really thoughtful description that conveys meaning. I think Michael used the term word picture.
Yeah.
Every time that comes up, it's like a red flag for me. I get annoyed at the fact that people don't seem to focus on the one thing that radiologists produce, which is reports, and that's
Hmm.
being really devalued.
So people could check out that Radiographics article. We'll put a link in the show notes. But better still, you could, if you've got an all access pass, check out the lecture that Michael recorded this year for the conference. That was called "Revving Up the Radiology Report." That's in our lecture collection. And also earlier in the year, he recorded a mini reporting workshop with Miranda and with Jeffrey as well.
Mhm.
So check those out. They've got CME credits as well, Gaylord.
And there was one more thing that was related to this idea of how you craft a report, particularly the conclusion. And it made me think of a quote that I recently read by Edgar Allan Poe that I thought we should really be printing these as Radiopedia posters to be put up in reporting rooms everywhere. And the quote is in one case out of 100, a point is excessively discussed because it is obscure. In the 99 remaining, it is obscure because it is excessively discussed.
Yeah.
And that, every report that is essentially normal but has a 4 or 5 line conclusion,
Yeah.
that's those ones. Occasionally you need a long conclusion, but most of the time.
I'm just thankful that I worded my conclusion nicely in that case I shared with Michael earlier in the podcast,
Uh,
because I wasn't really thinking that I was going to be critiqued on my report writing technique, but it worked out okay on this occasion. I wouldn't want him to see some of the other reports I've written in my time.
Maybe Michael could have a TikTok channel that is Michael reacts to Dixon's reports
Oh, oh,
and
that'd
he
be
reads them out and it's like, oh, that's rubbish.
yeah,
That's
yeah.
rubbish.
I think that could be a day 5 session at Radiopedia 2025. Seems easy for me. I just supply the reports and then he
Yes.
reacts. We probably should wrap this episode up, Gaylord. How can people get in contact with us?
Well, you can email us at podcast@radiopedia.org with any ideas and or feedback. And you can also join the Radiopedia community chat for free in our website. And we also have stuff on Instagram and YouTube and TikTok.
And if you want to help support Radiopedia, then you can become a paid supporter via the website or purchase an all access pass to our online courses and conference. In doing so, you'll be helping us to give free conference access to people in low and middle income countries, 125 of them. And What else can people do to help us out, Gaylord?
And you can also help us out by leaving a 5-star review in the podcast app of your choosing.
Yes, yes. And word of mouth, let people know. Gaylord, it's been like 4 or 5
It's
weeks since we
been a
recorded
long time.
recorded. Yeah, it's probably too long. Wow, we've got to work out so 1 week was too short, was too close. Every second week was too much. Now we're finding monthly not enough.
Maybe 19 days.
What's the word for every 3 weeks?
A prime
19
number.
days.
It has to be a prime number.
Yeah, a prime number. So no one knows when the next episode's
Do you
coming
know
out.
our case of the day on the homepage, which is now, surprise, surprise, different every day, used to be every 19 hours. And the reason for that was because that way it would change at a different time zone for each, like no time zone would be preferenced by getting a new case always in the afternoon.
You thought people were hanging out for the new case of the day, did you?
Well, I just thought it was an interesting idea because cicadas do this. Do you know cicadas hibernate for a prime number of years?
Oh, really?
Yeah,
Why
and
is
that's
that?
thought because that way they're harder to get in sync with for other animals who rely on them as prey because they swarm.
Yeah, because I remember hearing something about how 2 different types of cicada or cicadas, whatever it is,
Cicadae.
are due to pop out of the ground at the same time, and that's kind of a
Yeah.
very rare phenomenon. And then you have
Well,
these
there you go.
massive.
If you've got prime numbers, then it'll only happen once in a while.
Ugh,
There you go.
mate,
The things you
this is
learn on a radiology podcast. Not much
the things you
radiology,
learn.
but
And also, like, when you look at the end result of this podcast, even after Murph removes multiple of these little side conversations we've had, there's still probably going to be a lot of random ones left in here for the listeners.
that's kind of our MO.
All right, well, we better do the little sign off here, and we'll catch you all again sometime soon in the reading room.
Stay rad, everyone. Stay rad.
Stay rad. All right, I'll see you next month, maybe sooner.
Yes. Hopefully.
Bye.